Thank you. I'll just share my screen in a moment. So I hope my screen is visible.
Yes, sir, it's visible.
Okay, wonderful. So good evening, everyone. And at the outset, again, I would like to thank Dr. Gujral for giving me this opportunity once again to discuss with you the quality assurance in hematology lab. And I have no specific disclosures to make. And this is what I have done. I have put my presentation into following subheadings. I'm giving you a little bit of a preface. I'll show you some very important and interesting cases which kind of give you an idea why talking about quality is important. We'll talk a little bit about standardization in hematology in general. We'll talk about some concepts and terminologies of quality assurance. We'll talk about quality assurance, how the whole thing is actually looked at from the hematology standpoint. We'll talk about IQC, EQA, which again, you might be some words which a lot of you would listen to in your routine practices sometimes, but may not be able to make head and tail of what it's all about. And we'll also talk about how PT or EQA is actually happening in our country at the moment. And finally, some summary and take-home message. So I generally start my presentation with a picture which I'm showing you in front of you at the moment. And this is, I'm sure if I would have been in person in front of you, I would have asked you, and I'm sure all of you would have said it's an aeroplane. Now, why am I showing you an aeroplane in a presentation which is dedicated towards quality? The idea is that when all of us, when we have traveled by aeroplane, we have never thought that, the aeroplane is not going to take us to the destination. We always feel that we'll get into an aeroplane, it'll fly off, and it'll get us to the destination. But how do we know that it's not going to have any goof ups in between? It's not going to crash land, etc. The fact of the matter is that there is something called reliability and trust that is associated with aviation industry anywhere in the world. So if I ask you a question, how dangerous is healthcare, and give you analogies from various possibilities which happen across, globe with us, the examples are like, for example, if you look at newer nuclear power disasters, or you look at European railroads or scheduled airlines, you have one death, less than one death in 100,000 encounters. And when you go for driving, and we're not talking about driving in India, we're talking about driving, people who are driving properly, and then chemical manufacturing, there's usually one death in less than 100,000, but more than 1,000 encounters. And then comes more than one death per 1,000 encounters. And just imagine the healthcare part of it actually falls into this category, wherein there is 1 in 1,000 chance of, having a death kind of an encounter. So healthcare, obviously, when you look at it, is a pretty serious business. Now, what are the various types of errors which generally happen in healthcare? Now, by far, majority of the errors which happen or the adverse events that happen usually result from surgery, right? But let me tell you, the diagnostics are not that far behind. In fact, in one of the studies, if you exclude the non-operative events, non-surgical events, it's been shown that diagnostic errors were one of the most common errors which actually caused harm to the patient. Now, when I show you this picture, I'm sure at least the boys, who are in the presentation at the moment would have easily picked up. She is Angelina Jolie, and we know why she is, what she's actually been actually famous for the last few years. The idea was that she went ahead and got her test done, which was for BRCA testing. And based on that one test, she took a massive decision of her life of undergoing a bilateral mastectomy with bilateral salpingo-oophorectomy. Now, taking a decision like that is not a tiny thing, and all that was based on a test. Mind you, such a test cannot be, just wishy-washy. It has to be a very strong and a very correct test for the people to take decisions. So in today's day and age, if you look at the literature, you say it's very clearly mentioned that almost 70% of medical decisions, and in fact, if I exaggerate a little bit, and I'm really not exaggerating, it's really happening nowadays, more than about 85 to 90% of medical decisions today are either taken directly as a consequence of a laboratory test, or a laboratory test is ordered for confirming what they have thought of either clinically or radiologically. So for all practical purposes, evidence-based medicine is heavily dependent on a laboratory test. So let's change gears a little, and now let me tell you, when we talk about quality. So I've been able to emphasize on you that your role as a laboratorian is extremely important. But when we talk about quality per se. How does it come to us as a medical college student? So for me, way back in 2003, when I was appearing for my MD pathology exam, for me, this was nothing but a major question. And we obviously would have read about it like the same way and tried to, kind of vomit it out. But gears changed, and in 2004, I started working in one of the large labs in Delhi in one of the major hospitals. And there I got what is called the auditor and auditee experience. It's in that auditor auditee experience that I realized that there is something got to do with quality in our routine practice. And interestingly, the person, the auditor was actually asking me a question. He said, how do you do a particular test? And I said, okay, we do it like this, etc., etc., etc. And then he says, how do you know that, this is to be done like that? So I said, well, it's given in DAISY. He says, no, don't you have an SOP? And my question to him was, what is an SOP? So little did I realize that I didn't even know what SOP is. So SOP, stood for something called Standard Operating Procedure. It was the same thing what's mentioned in the DAISY, but you put it across to your system to make sure that your system is following the current standard operating procedure, the current version of DAISY for that matter when you're doing that work in a lab. So if you look at it at that same moment, while I was being interrogated during the NABL audit, a technologist was summoned. And now this technologist was asked a question, why do you run quality control material? And guess what the answer was? The answer was, I do it for NABL. So if you look at it, nobody was actually oriented in early 2000s as to how the quality kind of should be looked upon, and what should it actually mean to you when you're trying to work in a laboratory as far as the quality assurance is concerned. In fact, if you ask anybody from that era, the only thing they will tell you that quality would mean a lot of paperwork. Well, I'm not trying to get into an argument here to say, yes, it's not paperwork. It is paperwork, but nothing is complete unless the paperwork is done is also an important aspect for us to remember. So let me show you some important and interesting cases. These are real life cases which have happened to me during last 20 odd years. And I've just taken a few of them just to illustrate the cause of quality for all of you. So this is the first case scenario. In fact, so if you look at it, for example, if you look at these two cases, it's a very interesting 2017, these were, I call it a tale of two reports. And why do I say so is because there were two reports which were gotten across to me by my boss. And he said, just have a look at these reports. And of course, it was something which he had scribbled on two sheets of paper. In one sheet of paper, these were the parameters which I got in front of me: a hemoglobin of 10, an MCV of 74, MCH of 22, and RDW of 17.5, with a serum iron which was low, TIBC which was pretty high, transferrin saturation which was low, and ferritin was also low. So when you look at this particular report on the first one, it is very obviously showing that there is iron deficiency anemia, and it's also corroborated by the serum iron studies. Now, the moment you get onto the other side, this report, it's looking almost similar as far as the CBC is concerned, but the moment you try to get into what is called the serum testing for iron studies, you're not able to make out the head and the tail of it. Why? Because here the iron has come almost within the reference interval. Your TIBC has lowered down significantly, transferrin saturation is much, much higher, and ferritin has also gone up. So with this, he asked me, so I said, who are these patients? He says, well, it's a single patient, and just 2 days apart, these are the kind of reports I got. Now, generally speaking, when we have reports which are not, meeting each other, most of us have a simple tendency to say that either of the reports is not right. One of the two has to be wrong. So that's what I said as well. And that moment he says, and I asked him, where are these reports from? He says, both the reports are from your laboratory. So it was a kind of a shocker for me. And my answer to him was, if both the reports are from my lab, both the reports are correct. And now I want to know who's this patient. So I realized that, and he said it's his mother, and I knew that his mother was undergoing dialysis at that point of time. And these two reports were actually in between. There was a dialysis event which had happened that had affected the serum testing significantly, but not so much on the CBC parameter. So you can imagine how this whole thing, actually affects two reports. And you were ending up, talking about a report which was one which was right and one which was wrong, as per the understanding that we usually have. This is another case happened in one of our cases. It was a 32-year-old female who was a case of relapsed acute myeloid leukemia for allogenic stem cell transplantation. She was stable, and a stem cell enumeration had been sent across, which was to be done on a flow cytometer using a classical Ishaj protocol. The cell dose, which we calculated based on the values that we got, was just 0.02. So for anyone who knows the concepts of stem cell transplantation, a value of less than 2, actually in a case of AML, far higher than that, because you would want a higher dose in such cases. This dose is just not sufficient. And mind you, this is an allogenic transplant. That means the person who has actually given us stem cells was a normal good donor. So we don't expect this lower value. So after this, what happened is we took a fresh sample mixed the bag thoroughly, took a fresh sample from the bag. And then when we did the sample on the repeat sample, the value came out to be 11.3 per kilogram body weight, which was well within the required limits for this case to be transplanted. So obviously there was something wrong with the sample which had been taken across here and given across to us for doing the testing. The third case was another very interesting case which happened to me in one of my previous places of work. This was a 55-year-old male, an army veteran who was actually post-valve replacement, cardiac valve replacement, and was on acetrom 4 milligrams per day. And he came for just regular PT-INR monitoring. This hospital had just recently started, and we had, set up our entire coagulation systems. And interestingly, when this patient came, he gave me a sample, and we got a PT which was non-coagulating. It was more than 200 seconds. And if you look at the patient, he was very insistent, that I have gotten tests done previously from a different lab where it was less than, 3.5. And that's what my doctor has prescribed it to me. So he said, can you give me this sample? I'll get it done from some other place. So he went back and I gave him the same sample, and he got an IRR of 3.4. So in this particular case, why were we not really concordant is because there is something called reassignment of ISI. Sometimes when you get the sample, when you get the reagent, this reagent may not be what it actually was ought to be, and you have to verify the ISI value of the reagent to get the values which are correct. So if you look at PT-INR, INR at lower limits was always matching, and our QC was passing on very well. But the moment the INR goes on to the higher values, the values would actually become too high for us to get the value which was correct. So therefore, in this case, we had a major challenge, which was reassignment of ISI, which we did later on. Coming to another case, if you look at this, these pictures, this is a hemoglobin HPLC of a patient, who has very classical sickle cells in his peripheral blood sample. And obviously, when you have sickle cells here, you have a sickle hemoglobin, which is coming out in the sickle window of 88% with slightly raised F and slightly raised A2. This was nothing but a homozygous sickle cell disease. On the face of this, this is how it looks like. But as a part of a routine process, when we report hemoglobin HPLC, we also do what is called the sickling test, just to confirm that, it's no other hemoglobin which is eluted in the sickle window. When we did a sickling test, in a prototype, this is how sickle cells will be. But when you look at our case, this is what happened. There was no sickling at all. Zero sickling, no sickle cells. But this didn't explain anything, because if we go back and see, we had classical sickle cells in this case, yet we were not able to get the sickle cells or the sickling in our patient sample in the case. So we were kind of foxed as to what to do next. So we decided, okay, let's just take it up and, review and see where we've gone wrong. So we used fresh set of reagents again. And now when we use the reagents, we were able to get very classical sickling that we were expecting. So in this case, if you notice, the reagents had kind of, given up, and they were not conforming to what was expected out of them. And thus, reagent itself was an issue while doing this test. The next case is a case of a 4-year-old male who was a known case of precursor BALL, post-induction marrow for MRD. And this is pretty early, when MRD was just being kind of started in flow cytometry. And obviously the case was reported MRD negative. The only problem is that this patient relapsed just in about 2 months' time. So obviously, when we went back and we realized that there was a minor population of cells which we had missed at that point of time. So important point is, even in this case, while everything had been done correctly, the interpretation of the case was a big challenge. Another case wherein a 54-year-old male with generalized lymphadenopathy was not showing any significant abnormality in the peripheral blood, but bone marrow was completely infiltrated with a lymphoid cell infiltrate, and flow cytometry was reported as CLM. The only thing is the molecular studies turned out to be translocation for 11 and 14, and this was nothing but a mantle cell lymphoma, which was eventually figured out on flow cytometry itself. So now if you look at issues in all the three cases, the first two cases, you have the pre-analytical issue. That means this issue was with the sample. If you look at the case 3 and case number 4, there was an issue with the way the entire thing had been processed, the technical issue. So it was the issue with the technique. And if you look at the case number 5 and 6, it was an interpretative issue or the analysis issue, which was actually affecting these cases. So the issues can be there with the sample integrity, issues can be there with the technique, issues can be there with the analysis and interpretation, which is otherwise the pre-analytical phase, the analytical phase, and the post-analytical phase. And all this actually, to obviate them, to take care of them, you need adequate training, experience, and application. So this is, so if you understood the whole concept behind these cases, the idea of showing you these cases was to point or put forth the case for ensuring that the quality assurance becomes a part of our routine practices. Now, why do we need to do that is because behind every sample, there is a patient. And more importantly, it could be me in the tube. And that's what is more important for us to remember, that if I will be in the tube, what would I want it to be for myself? Now, when you go to laboratory or a lab testing scenario, there is a lot of wish list, which most of us kind of carry, and we can look at the wish list from three distinct aspects. So if you look at it from the patient standpoint, you would want the patient is always looking for getting his test faster, wanting a reliable test, and ensuring that he's getting at a reasonable price. What does his physician or the treating doctor want? He also wants the same thing. He wants a correct result. He wants that it comes to him quickly, and of course, it should not be charged at an exorbitant rate. And what are you wanting? You're also wanting to make sure that you're able to do the tests properly, and you would also make sure that there are appropriate quality checks. So when you result it out, it is not kind of questioned by a third party. So if you look at these three scenarios, what are you looking at? You're looking at a patient, you're looking at a clinician, you're looking at a lab physician. All of them are actually wanting a rapid, reliable, and a cost-effective test. And this entire thing obviously then becomes patient-centric. So therefore, quality assurance per se is beginning from the concept of getting the right thing for the right person at the right time, with the right way, and in the right proportion and pricing. So when we look at a quality management system, in terms of patient care and, patient centricity, and especially on the laboratory kind of a concept, there are three important aspects to remember. The first aspect is the pre-analytical aspect, the analytical aspect, and the post-analytical aspect. But while these might just appear like three words to you, behind the scenes, there are just too many things which are happening. For example, you have the preparation of the patient, which is equally important. You have the importance of ensuring that there is competency of the people, who are actually evaluating the test or doing the test, that's taken care of, or even taking the sample, they should know what they are trying to do. Ensuring that the sample is received in the right conditions, and then processed according to the right system is also equally important. Where you have to transport, you need to transport in the right manner to the lab. And then eventually, when you're analyzing the sample, ensuring that the analysis part of it is going across just as the way it would have been expected in a classical good laboratory. And then finally, you have to keep the records and also report it out to the patient. While all this is happening, you also have to keep in mind that there is a lot of data and lab management. There is safety of the patient as well as the laboratory professionals. And then finally, there is service as well. So if you look at the entire gamut of these activities which are happening, they're all activities which are happening parallelly and need to be taken care of in a systematic manner. So if I look at the role of the lab today, the role of the lab is pretty important for a good medical practice, and ethically also it's important for us to have reliable, reproducible, cost-effective tests in a reasonable time frame. And then, of course, when we look at the colleagues, who are working within the system of the laboratory, they should have an opportunity for training, career growth, safe work environment, and of course, doing some research and innovation would be like a dash of lime on the already beautiful dish that we have. Now, quality assurance, therefore, is not only for NAPL. While it's an important aspect of the quality assurance in majority of the labs across the country, you should also remember that while it may be some degree of paperwork, you should also remember that yes, you might need to develop and retain the quality control charts and other material. You might have to select the right choice of methods. You might have to have proper education of the personnel. You might have to have appropriate handling of specimens, correct reporting of results. The real purpose of quality assurance is to determine how correct or incorrect the results are emanating from the lab that you're working for. And this eventually is important because we need to satisfy the patient's, patient centricity that we are trying to work for. So quality assurance as an objective is intended to ensure reliability of the laboratory tests for the patient care. Now let's go to the next part of it, where we talk about standardization. And that's an important aspect for us to, kind of look at. Uh, a few years ago, I went to Pittsburgh, and this is the charger that I carried with me. This was my phone charger, and this was the socket where I needed to fit in the phone charger. Now, for all practical purposes, is it possible for me to fit it in these kind of slots? The answer would be absolutely no. But is there something that I can do to ensure that this gets charged into this, kind of a socket? Obviously, you have what is called a universal travel adapter, and obviously this travel adapter then can be fixed into the US kind of slots, and you're able to get your phone charged. By the way, at that point of time when I was trying to do this, activity for understanding the standardization of charging part of it, would you know that there are just so many type of sockets and plugs which are available globally? And if you look at it, these are the most common ones which are used in majority of the usual countries which most of us visit. So even within these different slots, look at various types of slots which are available within the country, within India as a country itself, and of course the rest of the world as well. So when you have this kind of variability, in terms of the plugs and the sockets, imagine the kind of variability that will be there in different laboratories with human beings so diverse and different, and their thought processes being different as well. So to standardize the entire concept, there is a standard which all of us like to follow globally, and this is an international standard which is by number ISO 15189. The current version is 2022, and that's what most of the people use in their respective laboratories. And this has also been adopted by NAPL and is also available as a standard for the NAPL for practice. Okay, so Indian standard obviously is the one which you can, pick up, and this Indian standard is much cheaper. It just costs about 800-900 rupees, whereas this one will cost about 16,000 rupees. But nevertheless, the standard says the same thing, and we are expected to buy it out of Bureau of Indian Standards and have a copy of it in our laboratories. But when you try to actually read up, sometimes you may find it a little too difficult to understand. Nevertheless, I don't want to scare you, but just wanted to give you an idea that the standardization is primarily by using a reference standard, which is basically from the ISO. Now, as I told you previously also, quality assurance has got three major phases: the pre-analytical phase, the analytical phase, and the post-analytical phase. And how are they actually adapted is the pre-analytical phase primarily talks about specimen collection, transport, and recording the tests. And in such circumstances, we need to keep track of, what are the preparatory steps that one needs to take, the posture of the patient, if they're use of tourniquet, etc. In the analytical part of it, we need to ensure that we have the IQC available, which is the internal quality control. We analyze the sample, and for doing the test, we should have selected the right methods, the right instrument calibration, and the checks that should be available. And finally, post-analytical, processing the data, records, and preferably if we have LIMS, the transfer of data from the instruments and into the laboratory information system to give the report to the patient should be similar without any major challenges. Now let's quickly go through some terminologies which are used in quality assurance in general. So there is something called quality assurance, then there's a term called quality control. In fact, the two terms are actually, in fact, the three terms: quality assurance, quality control, and quality management. All three are used kind of interchangeably. However, they have their own intricacies with respect to their definitions. Then finally, you have accuracy, precision, or reproducibility, and accreditation. These are the usual terms which a lot of people use. We'll try and see how they actually come about. Now, when we talk about precision or reproducibility, you're trying to reproduce the same result that you got the previous time. If you look at these dots, the red dots which are here, they are all kind of falling in the same area, but they should have ideally fallen in the green area. So if they're not falling in the green area, they are not accurate. But since they're falling in the same area repeatedly, that tells you that they are precise. So the precision is there, but they're not accurate. And when you try to look for precision, this is your routine quality control material that you will use for precision. The accuracy part of it is that these dots, the red balls which are coming in, they're all falling in the same area. That means they are precise. And they were supposed to fall in the green area. That means they should have, gone into what is called the accurate area. So there is accuracy as well as precision when you're looking at this, right? You cannot have accuracy without precision. That's one thing which you need to keep in mind. And you can still have accuracy. You can have precision, but you may not have accuracy. That's what I showed you in these two slides, the previous and the new one. So for precision, you use controls, as I already told you. For accuracy, you actually use a calibrator. And then how do you test accuracy on a regular basis is by participation in an external quality assurance program, wherein they are actually testing whether you are accurate or to the defined value or the target value that one was supposed to get. Now, if you look at this result over here, what's happening to the lead dots? They are falling all over the place. They were supposed to fall in the green area. They're not falling in the green area. They're falling all across in all the areas. So that means they are neither precise nor accurate. Now, this is the worst kind of a scenario which can happen in a laboratory. You have no precision, you have no accuracy. So in such circumstances, doing a laboratory test is extremely dangerous for the patient care. Now, how do you ensure accuracy? How will you ensure that your test result or the target value that you should have achieved, you're always able to get, right? So for that, what you do, you have something what is called a calibrator. Now, calibrator is a very interesting and an important material, which is nothing but a reference material. There is something called certified reference material, and this reference material will have a known value, okay? And this known value in turn should be traceable. Okay, so there is a traceability, and that calibrator has a target value. Remember, calibrator should always have a target. It can never have a range. Though there are a lot of hematology analyzer companies, they'll keep telling you that calibrator will have a range, but for all calibrators there is a target value, and you are expected to get your machine to achieve that target value by adding what is called a calibration factor and adjusting it to match the traceable or the measured caliber. So this is how calibration factor is actually, helping to ensure that your value becomes accurate and comes to the right area that you're expecting it to fall. Now, how do you check for accuracy? You check for accuracy by running the calibrator in the sample mode, and that helps you to ensure that you are getting the calibration of the analyzer properly. So how do you kind of calibrate your hematology analyzer? It's done as a part of the standard process whenever you set up your instrument or whenever the instrument is going to be subsequently going for, quality assurance for a preventive maintenance. You use a certified reference material, which is a calibrator. And when the cal factors are actually added to it, the cal factors are actually able to give us the values which are relevant for that patient care. I will not get into details of carryover to that extent, but you must remember that when you run a sample of blood in any analyzer for that matter, it's a proteinaceous material and it also has cells along with it. So every time you send the sample inside the analyzer, some of it will remain on the tubings because it's a proteinaceous material and by its nature it's a little sticky. So therefore, to make sure that that part of it is taken care of, you use what is called diluting and eventually the cleansing agents. But despite doing that, sometimes you still will have buildup of the protein along the tubes. So this actually needs to be checked out on a regular basis to see how much of a carryover is there from the last sample to the fresh sample. And this activity is also done as a part of the primary, installation or the performance qualification during the installation process of an analyzer. And subsequently, whenever the analyzer is undergoing a preventive maintenance, you're expected to do this again and again. So during calibration, you'll do pre-calibration checks. You look at the instrument, look at the reagents, make sure that the calibrator is not expired. Do a precision check with during the calibration procedure, including carryover, linearity, etc. And then post calibration, run the calibrator as a sample because that will ensure that you're able to get your accuracy. And of course, run the re-level contours and see how much of a bias are you getting in that. Now, coming to internal quality control in hematology, and I'll be concentrating primarily on the analyzer performance. What people generally try and do is you need to take a control sample, which is usually a commercial control, and run it at least 5 times, if not 10 times. The idea is that you want to get the mean and the standard deviation around which this control value should then fall, and then check for the variation. The control material is nothing but a stabilized human blood, which is generally available from a company called Streck. You can also get it from your respective vendors, but eventually they also get it from vendors like Streck only. And once you get that material, you are expected to run it. And the important point about the control material in hematology is it's got a shelf life, which is not too long. So, and more importantly, there is also something called open vial stability. So the moment you open the lid of this, control, it'll have a stability of only about 7 days. So that's what one needs to keep in mind. That's why control running in hematology is a little, I would say, a little expensive and also a little different than usual conventional chemistry analyzer. And I'll show you that in my subsequent slides. So when you talk about control sample, when you run a control sample in the hematology analyzer, you get some values, and these values then are put in cross into the charts. The first person to do that was, the Walter Shewhart, and he gave us what is called the Shewhart's charts. And eventually, the Levy and the Jennings, they actually gave us the system of plotting it on a graphic plot called the Levey-Jennings plots. And of course, when we look at the Levy-Jennings plot interpretations, we have James Westgard, and of course now his son has taken over, and they gave us what is called these Levy-Jennings chart interpretation rules called the Westgard rules, which most of us follow. For example, there's something called 1-3S rule, and there's something called 2-2S rule, then a 4-1S rule, then 1-2S rule, and an R4S rule, which are all rules where you have to be very careful of running the samples, because the moment you have these kind of rule violations, this tells you that there is a problem with the instrument. But is it always the problem with the instrument when we run a control? The answer is no, because sometimes the control itself may have deteriorated and may give you values which may be off from what you are expecting otherwise. Of course, there are other rules also which are used by a lot of laboratories, like for example, the 10x rule, and then you have modified 10x rule, you have the 8x rule, and then you have the 12x rule also. Now, when you look at all these rules, most of these rules have not been specifically used in hematology analyzers, because you will invariably see that the window between the runs is too tiny. And then when you see the runs, they will give you, they will all try and fall on one side of the mean, especially if you're using the manufacturer's mean. So you will have to reassign the mean, and then you will get a classical zigzag pattern. And that's why 10x and 12x rules are generally avoided by hematology people. Okay, and then 7T rule. This rule is also important to remember, because in this case, you are able to see a drift or a shift in the analyzer performance from a negative to the positive value. And at times it can give you, and it may be the earliest harbinger of giving you the information that the instrument may be, kind of getting into a trouble. Now, what do you do when the control point is an outlier? You can have what is called a warning rule, which I told you previously, and you can also have what is called rejection rule. The rules which I just showed you, a slide before, especially the 1S and the 3Ss and 4-2Ss, they're all, kind of rejection rule. That means it's completely out of control. And in such circumstances, unless you have identified and corrected the problem, you should not test the patient samples. And that's what is important. And that makes sure that, the results which are going across to the patient are appropriate and correct. Now, there are lots of stats which are involved in quality control systems. You have something called mean, then you have a standard deviation, which can be 1, 2, or 3 standard deviations. And finally, what is called coefficient of variation. And I'll just illustrate it to you as to how one needs to get to do it. For example, let's look at the RBC values of the control sample, which has been run 10 times. If you look at these values, what's happening here? You have different values. You have a value of 4.58, and all these is in millions. 4.58, 4.55, 4.61, and then you have a smaller value of 4.49, 4.46. So there is some degree of variability in the values that you got over here. And now you take a mean of all this. So you'll, add them up and divide by the total number, and that will get you the mean. Okay. So this is your mean. The mean is 4.55. So this is how you get a mean of numbers that you're getting it. And I'm sure, all of us know how to get the mean, a usual mean. Now, to find the formula to find the sample mean is this formula, the summation by the number, and then to actually calculate the standard deviation, it is the summation of x, that's the numbers minus the mean, to the square divided by n minus 1, and this is the square root of that which we need to look at. And then the formula to calculate coefficient of variation, which I'm showing you here, is the standard deviation which you got from the top, and you divide it by the mean, and that gives you the standard deviation. So for all practical purposes, when you run quality control material, you're expected to calculate the mean, the standard deviation, and the CV. And an instrument is very good if your CV is very low. So if you have a CV which is low, you should be happy about it. Now let's try and do a calculation of the mean and the standard deviation based on the formulas which we saw. These were the individual values which we got. And this is the mean that we got after calculation in the last slide, right? And now what we'll do is we need to calculate, and so therefore we'll take the value minus the mean and take the corresponding values of that, right? And then we can square it up, because we have to take an under root of this value eventually. And that's what gave us the value of what we got just down there. That's the summation part of it. and the standard deviation is that divided by the total number of values, and that gives us the standard deviation. Now, on the standard deviation divided by the mean into 100 is what gave you the CV. So this is how the CV calculations are done. And though I would have preferred to send you this, but nevertheless, we'll not bother about it at the moment. Remember, calculation of standard deviation and mean and CV is equally important in all our parameters within the laboratory. Now, when we talk about control material has a value which has been defined. Okay, and if you have taken a manufacturer, the commercial controls from a manufacturer, they will have their own defined values. But despite they giving you defined values, you must ensure that you're running them in your laboratory in the hematology analyzer, and at least have a few values for you to set your own mean inside the laboratory, because you may not be able to get exactly the same mean what the manufacturer gave you. So analyze it and then get those values, and basis that you define your mean and standard deviations. Run your quality control every day before running the patient sample. It's an extremely crucial part of your activity in the whole day. Plot your Levey-Jennings charts before you start putting the patient samples on the testing. And fortunately, all this is now being done on most of the analyzers because they have a software of their own and they have a QC channel in that which gives you all these values. And then finally, what is happening? You're expected to, use Westgard rules or other rules which are available, for us looking at the QC data. But remember, when you do this, you can either do it manually, which was the practice almost about 3 decades ago. But today, again, you don't need to do it because all this is available either within the instrument software or a third-party software like Unity from Bio-Rad, where you can, actually set up your rules in such a way that it gives you an alert on its own, and you don't need to really look into it on a daily basis. Now, this is a classical LJ chart, and what you're able to observe is, for example, this value is completely off, and again, this value has gone into beyond 2S. So remember, when you have such a situation, identifying and eventually stopping the test is also important. And when you look at LJ charts, ideally, all three control levels should be looked in unison. Only then will you be able to apply all LJ charts. All right, so remember, the QC value of less than 2 standard deviation or more than 2 standard deviation, you need to really worry about them if their values have gone beyond them. And you should still remember 95% will still remain within the confidence limits. But remember, anything beyond 3ST is always very, very dangerous. So what can you do? You can use commercial controls, which most of us use in our laboratories today, because it's easier to handle commercial controls than to make your own controls. You can also do what is called retained sample testing. That means a sample which had been tested previously in the previous run, you keep it in the refrigerator, and then later on you retest the sample. And then you look at what is called moving averages or Bull's algorithm, and I'll show you that in my subsequent slides. Remember, the point is, why would you not want to use retained sample on a regular basis is because you need to test at all the three levels. For example, in hematology analyzer, you are testing pancytopenic samples as well as high hemoglobin, high leukocyte count, and high platelet values, and then also the normal values. So the QC that you're going to be using in your system should cover the entire analytical range or the reportable range that you're reporting in your laboratory. Now, establishing acceptable controls, within the commercial controls, as I told you, we need to run them. New lot should be run parallelly with the current lot. And once you've done that, you'll get enough data points, roughly about 5 to 10 data points, with which you will be able to set up your own mean. And based on that mean, on the 10 runs, you will then be able to run the sample. And this will ensure that you are able to get the data, which is perfectly just as the way we were expecting. Now, coming to the next part of it, which is called the moving averages or the Bull's algorithm. This is what is called patient-based real-time quality control, or PBRTQC. And this is something which a lot of people use as a part of their routine practice because it's fortunately available in our software systems in the hematology analyzers today. So you do what is called moving average of the quality control, or it's also called average of normals. The reason why we do that is because there is something called non-commutability of commercial controls. Because in other words, the commercial controls and the patient sample are not equitable. And that's why, looking at the samples which are coming from the patient samples itself, the data coming from the patient samples itself is what people will, kind of look at. So when we look at non-commutability, the idea is to ensure that the value which is coming out from the sample has to be homogeneous. Because if it's not homogeneous, for example, I have In my laboratory, we have a sample coming from gastro, a sample coming from onco, a sample coming from neuro, ICUs, and then of course the patient, the so-called health checkup. They're not patients; they're like supposed to be normal people. Now, when you have such a lot of variability, applying moving averages may become a major challenge. So the important point is that you have to know what are your inclusion criteria, what is your truncation limit, to what level can you actually put up your limits, and what is the data that you're trying to look for and seeing whether your instrument is performing correctly or not. Now, this is what is called the patient-based real-time quality control. And I'll just illustrate this in the form of a graph in the next. For example, if you look at this data, the gray line is very clearly giving you the lab data which has come, lab result which has come from, one of the samples. In this case, I think it was from albumin, one of the publications. Now we have set up our upper limits, we've set up our lower limits, but just see some of the values are actually going beyond. But what is our moving average on a daily basis with multiple samples which have happened? So this yellow line represents that. And if you see your instrument is reasonably stable till here, and suddenly see there seems to be some drift towards the negative side. So this, when you look at this data, this tells you that your instrument may be having a problem. You need to look into it and take care of it. Now, if you look at the classical uh, patient-based quality control versus the classical IQC, it's important for us to remember how do we do it. Now, patient-based, because it's patient-based, you keep getting samples 24/7. The frequency is continuous. Obviously, it's not going to be halted at some point of time. But when you look at the statistical QC, you will schedule it. For example, in our laboratory, we run it 3 times a day. I told you, in a classical commutability, that means how close is it to the patient sample. If you look at the patient one, obviously it's commutable because it's more closer to the patient sample. Whereas when you talk about a classical statistical IQC, which is from a commercial vendor, there is significant non-commutability. That means it's not very close to the patient sample in terms of its matrix. Then, if you look at what are the controllable phases, it's going to be controlling all your steps, the pre-analytical as well as the analytical steps. In the statistical one, it doesn't look at the pre-analytical part of it at all. It only looks at the analytical phase. Again, you can have a level. Usually, it's a single level, which a lot of people try to look at because you would like to get the normal ones rather than look at multiple levels. Statistically, obviously, multiple levels. Error detection, usually bias is picked up, and here bias and imprecision both is picked up. And then of course you need to validations before you do the entire activity as far as the PBQ RTQC is concerned. Okay, so from here we go to our laboratory. What do we do? In our laboratory, we have both the retained sample testing, or we also have the patient-based moving averages that we look at. We have the control charts in our laboratory with the test control on the material itself. We do duplicate testing as well in some of the cases. Delta check is a usual practice in majority of the labs, and we are no exception in our laboratory. And we look at mean patient data, as I told you, and especially in terms of hematology analyzer, there is correlation check on the blood film. And this, fortunately for our setup, has now become automated. So all the samples where there are any correlation mismatches, they will automatically have a blood film examination, which will get optimized on the digital platform. And in fact, we'll get an alert as well. So obviously, this is a high-end IQC kind of a scenario that we have developed in our laboratory, but majority of the people will actually at least level up onto the first three or sometimes the fourth one as well. So this is a classical, a Coulter analyzer quality assurance sample which has been run. If you look at it, this is for the RBC control data. And of course, here you can see for the WBCs, you can see RBC, and of course, you can also see the hemoglobin. Just look at it. It's like well within the mean. You have a standard deviation, which is far beyond this, and it's like zigzagging across very beautifully for all the 3 parameters over here. Now, this is a very typical classical QC which comes in a classical hematology analyzer. This is from Beckman Coulter 750, which I used to use once upon a time. This is from the analyzer called XE2100, which is a Sysmex analyzer, which I used once upon a time. And again, you can see all these parameters are giving you the values. Again, you can see the zigzag values. In fact, if you look at the platelets here, it's a little deviated here. But again, if you look at the if we would have reorganized the mean, we would be able to get the values which are going to be, kind of in a straight line. And all the values are also given in the numerical data on the other side. This is from another instrument called MindRay, in which again you have these QC data which is coming up. But if you look at the QC data, it is very obviously giving us values which are kind of comparable to the rest of the material. Now, what other things can you do as a part of the internal quality control activity? You have to look at, if you have more than one analyzer in your laboratory, you'll have to do a comparative study between the two. The other important aspect that we need to keep in mind is that most of our analyzers, we have a possibility of putting a sample in the analyzer, either in a cassette where it will be taken automatically inside, pierced, and the sample will be taken in. It will also be, we can also just open the lid of the tube and push it into the analyzer. And this is the open mode. So you have two modes. What we need to do is we must make sure that at defined intervals, we do this difference between the two modes also is checked on a regular basis. The reason why you do that is sometimes one of the modes can have increased proteinaceous deposits and may not be aspirating the right amount of material. And we need to keep a track of that as well. Then lot validation is also equally important. With each passage of, when you use a different reagent, not only is the QC reagent different, we also have to ensure that the other reagents which are used on a routine basis, they should also be checked with every lot that is changed. As long as your lot remains the same, it should be okay. And finally, correlation with the peripheral smears becomes equally important. Now, coming to the retained sample testing, which I showed you in my previous one of my previous slides. Why do we do retained sample testing? Now, retained sample testing is done basically to check your storage conditions. Okay. So you take a sample which was done, say for instance, yesterday, you've kept it in the refrigerator, and now after 24 hours, because that's the time that you say that after which you will discard the sample, you want to see whether your sample which was retained for 24 hours is giving you consistently similar results or not. In other words, you're actually testing your storage conditions. So that's what happens when you do a retained sample testing. But at the same time, you're also generating data. So when you generate the data, you're also able to do what is called precision study, which is nothing but an IQC study or internal control study. So here again, you are able to use the data from the previous day, and this can also help you to monitor your analyzer performance. You must remember that as the time advances, a lot of the parameters do get altered over 24 hours, and you have to actually determine what is your acceptability limits for retained sample testing when you're doing it on a hematology analyzer or any other analyzer for that matter. Coming to the last bit of it, which is nothing, which is otherwise called, a lot of people prefer to call it external quality assurance assessment scheme or assurance scheme, or EQAS is something which a lot of people talk about. But the ideal term for this is proficiency testing. EQAS is actually a registered trademark of Bio-Rad. So therefore, I refrain from using EQAS. EQA, that's external quality assessment or proficiency testing, are the preferable terms for this. Now, what do you do in this? The simple methodology is that there is what I call a challenge sample, which comes from a proficiency testing, provider, and that has a target value, which either is determined upfront beforehand in some of the cases, but in majority of the cases, it's calculated later on by the proficiency testing provider by giving what is called a Z-score or a deviation from the deviation index, which is what is also a standard deviation index, which is given. And based on what is the value or a consensus value that people got for that particular parameter, for X parameter on different analyzers, and basis that, how far away are you from that? Now, this is going to test your accuracy, because EQA is actually a target value that you're expected to get and depends heavily on the calibration part of it as well. And it also is able to identify the biases in your instrument. For example, if you start getting positive values all the time and there is a trend which you're seeing upward trend, you know that there is a bias in your instrument, or a downward trend in your instrument will give you a negative bias in your instrument. So proficiency testing can potentially tell you beforehand as to where your accuracy might be getting jeopardized. You must also remember that cannot be picked up from a usual precision study, because your controls are actually coming from the same vendor and you're not able to get hold of the differentiation in terms of bias, though there is some degree of it which can be picked up. So what you get is what is called the deviation index or the Z-score. You can also define, if you're not having a PT provider per se, and then you're having compare it with another lab, you will have to define which lab is going to be the standard lab and against which lab is going to be assessed. That also needs to be done. And of course, cell morphology, or even the retics, which are actually done manually, also need to have what is a component of EQA. All this should be done. I know we don't have it in majority of the cases, but this is done by some of the people. For example, this one is from the RCPA, which is the Royal College of Pathologists, Australia, and they are able to, give us this is from the AIMS one, AIMS EQA program. And then this part of it is from the RCPA. So the RCPA program is a far more in AIMS program, generally they'll just give you values and stuff like that. But when you go to the RCPA like program, they're able to get your scores. They're also able to place you where exactly you are, and they're also going to give you the trends, which you're getting in your system to define as to what you should be doing next. And this is the survey which they give you from our CPA and your survey and the result sheets. And finally, they're able to give you where you stand in terms of your testing. Now, let's say you don't have a PT program available. What are you expected to do? In such a case, there is preferable one is what is called the inter-laboratory comparison. That means you should try and have a comparative program with the laboratory which has similar program as yours or similar instrument preferably with similar kind of testing principle. If you are not able to get an interlaboratory comparison program, which can happen in some of the remote places across the country, in such a case, you will do what is called a split sample testing. That means you just take the same sample, divide it into two, and rerun the same sample and get the values. Remember, split sample testing will always get you primarily the precision, even if you're doing it like a PT activity, but it is the best that you can do under those circumstances. Fortunately for hematology, most of the parameters are nowadays covered under proficiency testing by one or the other, PT providers. So therefore, it's not really required for us to worry about it, and we are able to handle it. So if the EQA results are out, what are we expected to do? We're expected to go back, check our IQC results for that period when the EQA sample was analyzed, and relook at whether we did the right thing when we were running the sample or not. Also, you must remember your EQA provider will actually tell you, what they are actually running the sample on. For example, in one of our analyzers, which we had started in one of our newer hospital laboratories, we ran a sample, we had got a fluorescence channel in that analyzer. Now we ran a sample in the fluorescence channel and we got a certain value of platelets and we put that value in the PT provider's, result sheet, the AIMS PT provider's result sheet. What happened to us is we failed twice. Every time the results were not right. And interestingly, when the same samples were run on the three-part analyzer, which was an impedance-based analyzer, those platelet values were actually closer to the STIs, the values which were expected to get from the provider. We realized then that, the program is not oriented towards the fluorescence-based platelet counting. It is oriented more towards the impedance-based platelet counting. So therefore, choosing your EQA provider is also an important aspect to keep in mind. And when you are not having the right methodology which you are expected to handle, then please don't run samples on such kind of a state. So when you look at the IQC and the EQA together, you get what is called the total quality assurance. Now, when you have heard me in all these, slides so far, what did we achieve, right? We were able to show you that you can standardize all functions of the laboratory together. I think I was able to show you that there is something called quality monitoring, which we were able to do in all these cases. We were able to identify and correct the problems, of course, meet the accreditation requirements, which are set by NABL, and of course, have a quality culture amongst our employees. So if I summarize, what do we mean by quality and good lab practice? So you need quality in all the three stages, the pre-analytical stage, the analytical stage, and the post-analytical stage. And for the laboratory tests, you need to make sure that you have a clinical diagnosis. From the clinical diagnosis, the patient management takes place. Thank you very much. This is my lovely team, who we work together. And of course, these are some of the acknowledgements which I would like to do. A lot of acknowledgement to my mentor, he's no more, Professor Sood, who was the one who actually initiated me into the concept of quality and made me believe that quality is not only for paper and it's also meant for your routine practice. Thank you very much for your kind attention. I'll be happy to take questions if there are any.
Thank you, sir, for such an engaging talk. Let me invite Dr. Subramanian, sir, for his input.
Thank you, Anil, for covering a lot of things. So one or two points which I would like to add is one of the weak points in quality control of any lab is pre-analytical. One. Second, cell counters generally are very stable, except in one place, which is the platelets. And the common complaint when you run a CBC is going to be with platelet. In that complaint, the most common reason why platelet goes off is because somebody during collection has not mixed the EDTA well. So EDTA is an insoluble, relatively insoluble substance as compared to other anticoagulants. So anybody, I'm sure registrars are doing their collection. So ideally, after collecting an EDTA, you are supposed to mix it by inverting 8 times. So just look back when you do, how many times inversion does it happen? And you will realize that if you don't invert it fully, then you will really have a very common problem of platelet counts and spuriously low platelet count. So these are very common issues in most laboratories which come in. So if I'm getting a complaint that you gave a falsely low platelet count, yesterday you gave it very low, I just repeated it and it came normal. Then the first thing you have to think is, what is your collection happening? So that is one of the things. The other area where a collection or pre-analytical variable is very, very important is, of course, coagulation, the way you do venipuncture, especially for high-end coagulation, as well as even, sometimes in shortcuts, people take the sample from the same place where they are given heparin to the patient, or they don't inform where there is heparin. These are common things to keep in mind. Have a look at it. The third thing for the registrars, I would say, is everything doesn't look calibrator. The calibrator is only required when you are measuring in a numerical value. So a calibrator is for all analytes where your measurement is on a numerical value. So if you have a qualitative value, then you don't require a calibrator. So controls and calibrations are generally done. Ideally, we should be, I'm not saying for any particular test, but ideally, our way of doing if possible, is the calibration. But generally, calibrations are very expensive and tedious. So we calibrate at regular intervals and monitor the performance of the instruments using controls in between. So just running controls without calibration is also not a good practice. Some labs do it, but that's not a good practice. And calibrator, you always use the reference material. In the past, I have seen sometimes the instrument, people bring a sample from another lab which has been run on a cell counter there and use that value as a calibrator. That also is not a good way of doing a calibration. I think Dr. Handu has covered, so if anything further, Anil wants to hand.
Okay, I was just going through the chat box and I'm seeing 2 questions there. So one which is mentioned, could you please brief on quality assurance and coagulation lab? Okay, so I mean, it would honestly be a full talk, but nevertheless, I'll just give you a very quick 2-3 points about hemostasis laboratory. Number one, hemostasis laboratory quality assurance is different than what you get from the rest of the quality assurance. And the reason is that it is heavily dependent upon the reagents that you use. So therefore, and a lot of the reagent can also vary considerably. So that's why when you set up your QC for the coagulation laboratory, every time the lot changes of the reagent, for example, PT reagent changes, you have to make sure that you calculate what is called the mean normal PT. And then you also make sure that, if in case, and I showed you in one of my cases, that sometimes you might even need to reassign ISI. So that's one aspect which you need to keep in mind. Second important aspect is with respect to the APTT reagent. Remember, in a hemostasis laboratory, when you talk about APTT reagent, the APTT reagents which are available in the market, cover varied have varied sensitivity. For example, if you use a reagent like Synthesil, which I use in my lab, it's relatively sensitive to lupus. But sometimes, especially in when you have change of season, you have these small little transient lupuses which start coming up in people, and this reagent will exaggerate the APTT while there will be nothing wrong with the person. So remember, choosing the right reagent for your circumstances is also equally important. For example, I would prefer to use a relatively lupus insensitive reagent in our routine practice, especially for preoperative screen. That will ensure that I will not, kind of reject cases for on a preoperative basis. So that's another thing. Third is when you set up your reference intervals for the reagents, you have to make sure that you run your 20 samples in hemostasis, which is different than what you do for the rest of the cases. You don't do that for hematology analyzer. You do it only for hemostasis. So these are the few things which I would want to suggest. Of course, as I told you, coagulation is a little, it in itself is a very longish topic for hemostasis, as far as the quality control is concerned, and that itself can, be a separate talk. But I think these small little things which I just told you might help you. The other point which I would like to make regarding hematology part of it is, if you look at hematology analyzer per se, there is only one standard in hematology analyzer, and that's for hemoglobin. That's the only traceable standard. Rest, if you look at the hematology analyzer, it's only got a defined, or what should I say, a method which is there. So you're calibrating a method. You're not really having a traceable standard for any other thing other than hemoglobin. Keep that in your mind. There's another question which I saw in the chat box which said, what can be the possible reasons for low PT values apart from high temperature of samples coming to the lab? Now, I'm wondering, what does this low PT value mean? Uh, I mean, are we trying to say that this is a PT value, prothrombin time value here, or I couldn't get it. What exactly are we trying to see? But yes, temperatures can affect the coagulation material. You know, uh, and problem with the PT is, you know, the control material for PT. The moment you reconstitute it, you're expected to finish it off in a stipulated period of time. So if you don't do that, the QC material, whatever values come out of it later on, they might not be reliable. In our small little study that we did in our center for the prothrombin time, we realized that this on room temperature, once reconstituted, the QC material remains stable only for 4 hours. After that, it starts giving you very off results. So we have to be very cautious when we're using a PT, control material, which is reconstituted. I'm sure you would remember that for coagulation, majority of the PT material or even the EQA material which comes to you is lyophilized. And again, when you reconstitute lyophilized material, keeping a track of what you're using is also equally important. Okay, so you're asking, there's a question which says, are there any guidance documents or references for inter-instrument comparison? The answer is absolutely yes. For hematology analyzer, there is a document from CLSI, which is called H26A. A stands for approved. H26 is the document number, and it talks about method comparisons in hematology analyzers. And it's a very beautiful and a very nicely done document. The only thing is that it's a paid document.
And not easily accessible.
And it's a bit expensive. Yeah. But if you actually go online and you try to look for method comparisons, you will get exactly the same document in the form of a PowerPoint, which somebody from US has already done it. So you download that PowerPoint, you'll still get the same document, but in the form of a PowerPoint, which helps you to actually understand what to do.
Yeah, only a couple of things I just wanted to add, I think I missed earlier. One is, a retained sample in my lab, we run it a little differently. We only run it for the 8-hour period because generally the CBC parameters are only stable for 8 hours. So our purpose of running the retained sample is you can have control deterioration. And if your control has deteriorated, you cannot stop the lab function. So if in those circumstances, a retained sample provides evidence that there is not a problem in your machine and it's a control problem. So we compare the retained sample value with the control values in some circumstances. So it is like a backup for our, when we are doing it in a CBC. So doing a retained sample is also an important factor for doing the CBC. The other thing was, like you said, calibrators are not only there for hemoglobin, and for certain things there are not even calibrations, like reticulocyte doesn't have a calibrator. So all these will create a problem when you're doing the EQA or participating in EQA for these parameters.
Yeah, in fact, it's nice that you said that, because what we need to remember is reticulocyte counts at low values between different analyzers are almost similar. So for example, if I get a retic count of 1% in Mindray, I will be able to get 1.1, say for instance, in Sysmex, or maybe 0.9 in case of Beckman-Coulter. But now when I get a value of say 12, let's say in Mindray, I may get 17 in Sysmex, and I may get 22 in Beckman-Coulter. The reason that we get it is because there is something called, calibration of the instrument vis-a-vis the standard reference. The standard reference is flow cytometry, and mind you, it is not a 45-degree angle, and you don't have that, classical, the comparison, that straight line in between. So because of that, you will never be able to get values comparing with each other at high values, but at lower values, then the comparisons will always be there. So retics from two analyzers are not comparable. Please keep that in your mind. And the PT provider also, in fact, the one who's giving you from, not for the analyzer, but for the morphological one, is from Ames. That again, anyways, has its own 30% CV. So, who's correct, I don't know.
So there's another question. What is the significance of sigma matrix and how to analyze it?
Okay, so sigma matrix, basically, the higher the sigma matrix, the better, so-called better is the lab, and lesser is the requirement for running a QC material. Well, while if you are able to get Six Sigma, wonderful, it will make sure that your lab is actually like right up to the top and comparable to any big lab globally across the globe. But when I'll come to you, assess you as an NABL assessor, I will not care about your sigma matrix. I will still ask you, have you run your QC material adequately 3 times a day, or whatever it was this frequency which was expected as per 112. Coming back to the sigma matrix part of it, it takes into account a lot of factors, including the QC material, running the QC material, and of course the performance in that, and how much is the variability. You can also do analysis basis, various statistical analysis which can be done to achieve the matrix that you're looking for. Generally speaking, most of the labs, the ones who are following the regular NABL practices, they would reach a sigma matrix of 5 any which way, because most of them are actually running the material properly and getting the data properly and then analyzing them properly. But yes, there are labs who do not achieve that. I agree.
Yeah, my understanding was in generally sigma metrics in healthcare generally somewhere between 2 to 3. If you are 3 or above, is generally very good.
Yeah. So when I talked about sigma matrix, of course I agree with you completely on the hematology and the coagulation front. But the moment you get into chemistry part of it, it reaches about 4 and 5. So that's like something where you are able to get it better. But yes, on a hematology and on more so on the coagulation front, reaching a sigma matrix of 5 is practically not achievable.
So that will be all. Thank you so much for such an informative talk. Yes, sir.
Thank you. Thank you, ma'am. Thank you, everyone. Thanks, Dr. Mani.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, Anil, for good presentation.